This PowerPoint will highlight the differences from our current PEWS charts at BCH and the National PEWS charts that will soon be in practice. National PEWS is rolling out at BCH in February 2024. BCH's charts were used as the basis for this design, so they are similar, but it is important that you know what has changed and understand how to use the new charts. If you are comfortable with our current charts, this PowerPoint should be enough to update you. However, if you would like more in-depth learning, there is an e-learning for health package available which you can view by scanning the QR code. This package explains all aspects of the chart with the exception of the listening to you system, as this is BWC specific. The age ranges are now 0 to 11 months, 1 to 4 years, 5 to 12 years, and 13 plus years. All elements at the top of the chart are to be completed. This includes the patient demographics, listening to you, alarm limits, and additional risk factors. Listening to you is a process we have in place to improve your clinical assessment. Martha Mills was a young girl who died of sepsis. Mum recognised Martha's deterioration. The clinical bedside team, who came to work to do a good job, felt that they had assessed correctly and did not feel Martha was as sick as her mother did. Martha's mum had no way to escalate her concerns. We must recognise that we have had similar cases at BWC. To give you a safety net for when parents feel their child is sicker than we realise, Listening to You gives parents a set of guidelines for how to escalate their concerns to the PACE team. This is in the format of a paper leaflet or electronically via a QR code on the chart. At the top of the chart, there is a section to sign along with a QR code to support all parents and carers receiving this information. This box must be signed on every PEWS chart to confirm that you have discussed with the parents and they have received a leaflet or scanned the QR code and that parents understand when they may want to use it. There is a QR code for both you and parents or carers to scan to view the Listening to You leaflet. This may be particularly useful for parents whose first language is not English, as the leaflet can be translated on web browsers. Please ensure physical leaflets are still available in your areas for parents or carers who may not have a smartphone. On the BWC internet page, you can click on either the speak or the globe icons to translate to many different languages. The speak icon supports audible translation, while the globe icon supports readable translation. It is important to inform parents and carers of this function if English is not their first language. Continuing along the top of the chart, patient-specific parameters and risk factors are now combined. If your patient has baseline vital signs outside of normal ranges, there is a space to document this in the additional risk factors section. For example, cardiac defects, whereby a patient's normal saturations are less than 90%. There is an addition of neurodiversity or learning disability, for example, if a child has autism, on the charts for ages 5 and above. For patients with neurodiversity, be aware of their individual responses to pain and physiological changes. The other risk factors remain the same. Parents and carers have a unique understanding of their child and can identify behaviours which might indicate their health has deteriorated. You must read the question as written. How is your child different since I last saw them? The wording has been designed to give parents permission and therefore the confidence to tell us what they have observed in their child. You must ask this question before measuring observations such as counting a respiratory rate or doing their blood pressure. This is so parents do not need to contradict us if they have concerns when we do not. If a parent is away from the bed space, this is now to be documented with a U for unavailable. And remember, this measure in itself is enough to trigger escalation. The respiratory distress guidelines have been updated to individually reflect the appropriate signs we see in different age ranges. Check these carefully before scoring. For ages 5 and above, you will notice the addition of tripodding and supraclavicular recession as severe signs. The tripodding position optimises the inspiratory breathing effort and can help reduce breathlessness. Children may adopt this position naturally when breathless and struggling to breathe. In this position, a child, whether sitting or standing, will lean forward and support their upper body with their hands on their knees or another surface. Supraclavicular recession is the indrawing of the skin above the collarbone and can indicate upper airway obstruction. Remember, these are both signs of severe respiratory distress and require rapid escalation. Within the oxygen saturation section, there is a box where you document you have changed your patient saturation probe site. When you change the site of your patient's probe, put a tick in this box. You will also see that this section has reversed. Saturations of more than or equal to 95% is now the top box in this section, with the parameter value decreasing as you go down the chart. Recording the delivery method of oxygen therapy is done in two ways dependent on the device being used. The documentation will vary depending on whether we are administering oxygen in percentages or litres. Oxygen percentage scale is on the left side of the chart, whilst litres per minute is on the right. If they are receiving litres, it is documented with an X as demonstrated in the first column in this example. We have used the scale on the right-hand side of the chart to document 2 litres. If your patient is receiving a percentage, it is documented with a dot, as demonstrated in the second column using the scale on the left-hand side of the chart. The value is to be written in the white box and the delivery method written below this using the codes on the chart. For patients on high flow, CPAP, BiPAP, or other ventilation devices, the delivery method will be documented in the top box using the RSD codes on the chart. Patients on respiratory support devices will always score a 4. The percentage of oxygen being delivered will be dotted appropriately and also documented in the white value box. The delivery method can be left blank as this is documented at the top of this section. Blood pressure now has the addition of derogation codes. This is to document the occasions where you have either made the clinical decision to not measure a blood pressure, for example, a patient with croup who you do not want to upset, or when you have attempted a blood pressure but it is unsuccessful. If you do not measure a blood pressure, in the value box you will document the derogation code based on whether a blood pressure has not been attempted, for example, completing respiratory only observations. This scores a 0. Or if you have attempted a blood pressure but it has been unsuccessful, for example, if a child is wriggling but you have no concerns. This also scores a 0. If you have attempted a blood pressure but the machine is not giving you a reading, for example, when blood pressure is too low or too high for the machine to detect, this is cause for concern and must score a 4. The temperature guidance that was previously shaded red for pyrexia and blue for hypothermia are now highlighted by boxes. If your temperature falls outside of normal limits, this is highlighted by coloured boxes. It still does not score. The nursing gut instinct box is now called clinical intuition. The purpose of this box has not changed and is there to highlight if you, as the clinician, have concerns despite a low PEWS score. Remember, this measure in itself is enough to trigger escalation. The sepsis guidance has changed. Check carefully before assessing for sepsis. If you are concerned that a patient may have sepsis, this is to be documented on the PEWS chart below temperature and is to be escalated appropriately. When escalating, there is a space to document what has triggered this escalation. This could be because a parent has concerns or you yourself have a concern. It could also be that you are escalating because of a PEWS score or that you have a specific concern such as sepsis or a change in AVPU. All of the above can be documented as per the codes and demonstrated here. There is also the addition of an escalation level box. This relates to which level the patient has triggered based on the escalation criteria, which we will show you on the next slide. The escalated Y/plan box allows you to document whether you have triggered a new escalation or if a plan is in place to address your concerns. For example, this may be if a patient has a high blood pressure and the plan is for them to have some nifedipine. This does not necessarily need escalation as you are actioning the patient's plan of care. This is the escalation pathway on the bottom of the chart. When escalating, one or more of these triggers will lead you to escalate care. You may be triggering escalation because of either a specific concern, such as sepsis, that your clinical intuition tells you a child is deteriorating despite a low PEWS score, that the carer question has identified a change that indicates the child may be deteriorating, or that the PEWS score has increased. Reading these guidelines will help you to understand whether the escalation level needs to be low, medium, high, or an emergency. Respond as per the highest level based on a change in any one of these criteria. For example, a PEWS score of 13 will trigger an emergency escalation. Once you have decided which level of escalation is required, the section below will tell you what you need to do. If we look at the emergency escalation, a PEWS score of 13 requires either a 2222 call or, in specialist environments, a rapid review. For example, if a child has previously had low PEWS scores and is now PEWSing a 13 or above, this indicates rapid deterioration and urgent intervention is required. You will put out an immediate 2222 call for a paediatric medical emergency. For patients whose PEWS scores have been elevated for a prolonged period of time and the medical team are aware, if yours and your nurse in charge's decision is that a 2222 call is not required, a rapid review can replace this. The next section gives you a time frame for medical reviews. You must state this time frame when escalating to medical teams. The last section tells you the minimum observations required between escalation and the time of review. Please take the time to read this escalation pathway and ensure you understand each section. The next slide is in relation to the escalation levels from this pathway. Once you know which level of escalation is required, document this in the escalation level box using low, medium, high, or emergency to reflect what level of escalation they have triggered. To allow a contemporaneous documentation of events, you will also document when you have escalated to the nurse in charge and clinician. Additionally, you can document when the clinician has arrived to review and also if and when you have called PICU. Remember, this is a national chart. DGHs will call for a transport team, such as our kids team. At BCH, you will contact the PICU team. When escalating concerns, read the ISBAR script to help you structure your escalation clearly and succinctly. ISBAR stands for Identify, Situation, Background, Assessment and Recommendation. If you have any questions about any of the changes to the new PEWS charts, please don't hesitate to get in touch.